Hello, everyone, and thank you so much for joining our webinar today. We hope you're doing great on this sunny day, but cold day, and we are excited. We hope you're excited as we are about today's session. Today's session is the last webinar of the Promoting Interoperability three-part series. So we've got some really good information, really good content for you today, and we do have some links available for you at the end of our webinar to review the previous two parts of the PI series. Before we dive in, let's just do a little bit of housekeeping. The information contained in this presentation is for general information purposes only, and does not attempt to provide medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, the accuracy, the reliability, or the suitability with respect to content. Also, during our webinar today, if you have any questions during the webinar or at the end of the webinar, please feel free to type your questions in the chat at any time, and we will make sure we get to that question before we end today's call. This webinar is recorded, and we will be sending out a link to the recording along with PowerPoint slides in a couple of weeks, so you can revisit this material covered today at any time. So we're excited to have you here and to engage with you today. And without further ado, let's go ahead and get started. I am joined today by my colleagues, Robin Kernel and Jerry Deason. They are quality improvement advisors here at the Kentucky REC, and I am Vicki Harden. I am also a quality improvement advisor here at the REC. So we're going to be covering quite a bit of content in this final session, so let's go ahead and get started. The agenda for today, we're going to be talking about the operations of a health information exchange. So health information exchange, the objective for the PI category, that is going to be our focus today. So we're going to give you we're going to share a lot of content with you in regards to HIE. So Robin's going to talk to us about the operations of a health information exchange. Then I'm going to talk to you about the measures and their specifications, and then how to maximize that performance. And then Jared's going to talk to us about maintaining your score, and then he will do a series wrap up for us. All right, so I just mentioned the two previous webinars in this series. So I want to take a moment to review some of the highlights from those sessions. A lot of this information you may already know, and if you did attend our webinars, you probably do know, but we're just going to do a little bit of a refresher. So the category weights for 2025 did not change. They still remain 25% for traditional MIPS, 30% for the APM entities, for the MIPS APM entities, and then 30% for your APPs. You must submit for a 100-day time frame. In July the 5th of this year is that last day to start that 180-day requirement. You must use an EHR certified at the current ONC regulation. We have that regulation listed in the slide, and you can visit healthit.gov to take a deeper dive into that criteria if you want to know the details of what it means to have a certified EHR. You must be connected to a public health registry. If you have previously attested to option 1 for any public health measure in the past, then you are required to attest for option 2 beginning this year. So if you attest 1 to electronic case reporting last year for 2024, then for 2025 you will have to test option 2, which is live and production validation. So you must attest yes to the SAFER guides. This was a yes or no requirement previously. So you could attest yes or no, and you would get points for this measure. But for this year, you do have to attest yes to the SAFER guides. So this is this is a really brief recap of the previous webinars, but the YouTube links at the end of the presentation will go in a lot more deeper detail about each one of the items that we just talked about. And so with that being said, that moves us into today's content, which I already kind of stated that it's dealing with the health information exchange objective. So Robin is going to start us off talking about its operations.
Robin, if you're talking to us, you are on mute.
Well, I sure am. All right. Thank you for that. So thank you, Vicki. As she mentioned, we are going to talk about health information exchange, and we're going to start with terminology. So the goal for HIE is ultimately for interoperability of various health records to communicate and share information. Ideally, this sharing of information would create a more robust personal healthcare record for all of us. The systems would communicate. We would avoid duplicate testing, see a full picture of the patient's care, identify gaps, be able to forecast testing or immunization needs. But what we've seen is that connecting to the exchanges via an individual EHR vendor hasn't been as seamless as one would have liked. So the health information exchange is the solution that allows the organization to share information through standardized formatting so that information is exchanged in a structured format. And then we have a HIS, the Health Information Service Provider. It's the solution or allows the EHR to share and communicate with technology outside of its system. So some EHR vendors have their own HIS and others have a contract with a third party. Some of those you may have heard of, Med Allies or Secure Exchange Solutions. And then 2 new terms that have become popular include health information networks. These networks have agreements and specific requirements on sharing data and information. Then we have qualified health information networks who've been approved by the Office of the National Coordinator's designated entity that meet the definition of qualified. And not all HINs are considered a qualified health information network, but we will talk about that in a few more slides. So we've got different types of health information exchanges or the method in which you exchange information. So directed exchange is what we are probably most familiar with. This is using a direct email address within your EHR to send a summary of care document to another provider or health information exchange. This option's been around the longest. I won't say it's been around since the inception of meaningful use, but pretty close. And in order to be meeting the requirement of a directed exchange, your secure email that you use will have the word generally direct, will generally have that word in the email address. Query-based is using a direction connection interface with a HIE to search for patient information. This requires some action by the provider or the designee to search or query for patient information and then incorporate that into your system. it isn't a fail-safe method in that the provider may view the information, but maybe not finish the steps necessary to incorporate that into the record, or the information is missing required fields and doesn't meet the requirements to be fully reconciled. And when we look at the requirements for full reconciliation, that includes allergies, problem lists, and medications. So query-based exchange examples, if you're connected with HIE, would be their platinum service. You could even, I think it's Care Everywhere, I think it's what it's called in Epic. So there's some options there. And then we have consumer mediated exchange. So think of this as your patient or yourself sharing some of your health data through mobile apps or using the patient portal to send your health records to another provider. So I mentioned QHINs earlier. Qualified health information networks are necessary to meet the TEFCA measure if you want to pursue that within the HIE objective. QHINs are considered a network of networks. There is a broker who brings together multiple participants to share information. And while looking at these slides, if you'll look in the blue boxes, the information there may be hard to read, but think of the one on the left. This could be federal agencies, health systems, and health systems, other federal agencies are all connected to an HIE, and then the end users are us. It's your providers. It's us as the people. The one on the right could be another group, and that includes your EHR, your product and analysis vendors, another EHR. It could be more than one EHR connected, and then it could be another health IT model as well. So I've listed the current approved QHINs here. These, there are 2 more who are working through the approval process to give us at least 10 total. As you can tell here, there's a couple that are actually EMRs, and we see Epic and eClinicalWorks. Some of you may be connected already to Commonwealth and MedAllies. If you have more questions about those connections, I'd reach out to your EHR vendor to see if there's any agreements that you might need to sign. You all would be considered end users, and I would want you to ask questions to see what all is required of you by participating in a TEFCA agreement. So this part of the presentation, we're going to split up a little bit. So I'm going to turn this over to Vicki, and we'll let her take us through the measures options.
Thank you, Robin. So let's take a look at the specific measures for this objective. So the HIE objective, it consists of 3 crucial measures, and we will dive into each one of these to provide you with a little bit of a deeper understanding for each option. So option 1, and I'm going to talk about this in just a second, is receiving and reconciling health information or sending health information. That is transitions of care or referrals, transitions of cares or referrals. So that's usually that's going to be your referrals that are made by your providers or ordered by your providers, and those referrals and that health information will be exchanged to the specialist or whomever electronically. So that will be your transitions of cares or your referrals and your electronic summary of care records. Option 2 is the bidirectional exchange. So that establishes a technical capacity and workflows to engage in bidirectional exchange via a health information exchange for all patients seen by the eligible clinician and for any patient record stored or maintained in the EHR. So we're going to talk about that a little bit more detail. And then enabling exchange under TEFCA. This is a newer option. And then Robin's going to talk a little bit in depth about the TEFCA option. And that's becoming a signatory to a framework agreement, common agreement of a QHIN, TEFCA enabled HIE. So Robin's going to talk a little bit more about that, but I am going to dive into the option 1. But before I do that, we're going to, how to get started with HIE. So today there's many models and business approaches emerging to support electronic health information exchange. Some of these include local or state nonprofit or government-sponsored exchange networks. Some are local models advanced by newly formed ACOs. And then, of course, you have the exchange options offered by your electronic health record. So that's kind of where you need to start is determining which exchange services are available in your area or in your state or within your EHR. And then you're going to talk, after reviewing those different types of HIEs, you're going to begin having conversations with your service providers to discuss the goals that you want to reach with having an HIE, internal requirements, the technology needs that you're going to need for that HIE to be set up, and any risk and liabilities that come along with having a health information exchange and making sure you have policies and things in place to mitigate those risks and liabilities. And then you're going to talk with your vendor. What are the capabilities with their HIE? What types of information that is supported? And what are those costs that's associated with implementing an HIE, whether it be through your EHR vendor or through your local or through your state HIE. All right. So now we're going to dive into the actual measure for this objective. One of the first option for this objective, and that is receiving and reconciling health information. So the denominator for this measure is number of electronic summaries of care records received using a CERT for patient encounters during the performance period for which a MIPS eligible clinician was the receiving party of a transition of care referral. Thank you for moving the slides. So it's going to be your number of electronic summaries of care that you're going to be transitioning through an HIE. So the numerator is the number of electronic summaries of care records, and the denominator for which clinical information reconciliation is completed using a CERT for the following 3 clinical information sets. So these are required. It has to list medication, it has to list medication allergies, and then of course the current problem list. Those have to be on your health information that you are exchanging. So required for this measure is required for promoting interoperability unless you are submitting for either bidirectional or TEFCA. It requires 1 at minimum in the numerator. If it pulls a 0, that means that you're not actually doing any type of transitions of care. There's not transitions of care, so you can actually be excluded from this specific measure. This measure is worth 15 points. And then you must submit data for that minimum of 180 consecutive days. And there is an exclusion, and that is eligible clinicians who receives a transition of care fewer than 100 times. Okay. Moving on to sending health information, very similar, just a different mechanism. So the denominator for sending health information is number of transitions of care referrals during the performance period for which the eligible clinician in the clinic is transferring to a referring clinician. And the numerator is the number of transitions of care and referrals in the denominator where a summary of care record was created using a CERT and exchanged electronically. So denominator is going to be your referral sent, and your numerator is going to be the referral sent through exchanged electronically through your HIE. Some of the same elements apply to this measure also. It is required for PI unless you're submitting for bidirectional or TEFCA. Requires 1 at minimum in the numerator. Again, if you have a 0 or if you have less than 100 fewer referrals, then that's you can be claiming exclusion for this measure. This measure is also worth 15 points, and you must submit data for the minimum of 180 consecutive days. All right, so Robin talked about directed exchange as a type of HIE. So we know this directed exchange kind of as direct secure messaging, and she did touch on that a bit in when she was speaking about her slide. So DSM allows healthcare providers to exchange patient information and other sensitive data electronically in a HIPAA-compliant, encrypted manner. In order to meet this objective, providers must use a certified health IT that includes a direct exchange. Some providers may work with a third party to obtain direct services, but most commonly, the EHR does offer those direct services for the organization. To utilize this type of HIE, of course, you need a direct address. And that's needed to exchange health information. And then the direct addresses actually look similar to an actual email address. And if we refer to the graphics on this slide, it kind of tells you what the differences is between just sending a regular email to how it compares to sending a direct secure message. So there's a lot more that goes into that whole direct secure message functionality. You have that standardized encryption, you have that identity validation, and then you have that end-to-end trust and liability. So the types of HIE sent through direct secure messaging are usually your continuity of care documents, discharge summaries, could be your lab results or progress notes, or immunization records or care plans. So that's kind of your overview of your direct secure messaging, what it means and what it is, and how it's different from a just a normal email. So moving on to, I can get my slide to change. Moving on, where can you get direct addresses? Okay, so direct addresses are available from a variety of sources, including your EHR vendor. I've worked with EHRs that they actually have a directory catalog within their EHR for you to utilize when looking up referral partners. You have your local health information exchanges. And then you have your private service providers, which are your HISPs that Robin talked about earlier. Your EHR vendor or your HISP may include a provider directory. If not, you can always use the Kentucky Direct Email Catalog via HIE. And we do have the link here to access if you would like to review that. And if you're looking for email address, if you don't have a direct email address for a specific referral partner, and we do hear that quite a bit, you can always go here to this link and actually search for that specialist or that partner and kind of retrieve that secure email and then add it to your catalog within your EHR. All right, so best practices for sending and receiving HIE. So some best practices are reviewing your EHR manual, making sure you know the steps that's required for that measure credit, where it's linking, making sure that you're documenting in the correct places, those types of things, just going through that workflow. Create your office-specific HIE staff workflow, and it relates back to that whole noting each step required for the measure credit. Train staff and providers on how HIE works in your EHR. And ensure when new providers join the practice, ensure that direct address gets added to that catalog. And make sure your providers are aware of this is, you can search for referral partners, those types of things through this catalog also. Electronically enter every referral transition of care into your EHR every time. So I'm sure you have a referral module within your EHR, or there's some way of tracking your your transitions of care and your referrals. Make sure that all of those are electronic if possible, so that you can get credit for this, credit for each touch, each transition of care within this measure. Review your summary of care documents for inclusion of all elements, making sure that it does have the elements that we did talk about before, such as medications, medication allergies, and the problem list. And then, of course, audit and review these reports monthly to make sure the numbers look, they look correct. Especially if they're low, and if they're low numbers, you may want to go back and revisit your workflow and make sure that everything is still flowing as it should, making sure your HIE is still working, those types of things. And then you validate the data and you work to address those discrepancies and missed opportunities, such as if there was a couple or 3 referrals that did not get entered in electronically, try to figure out, okay, so how was that a missed, why did that happen? Why was that a missed opportunity? And then review results and best practices in monthly meetings with staff. And that really does help when reviewing the data with your providers, seeing, those numbers and those percentages, and, trying to talk to them about the process, the workflow. I'm trying to figure out how we can get that number to improve. So that is option 1. I am now going to pass it on to Jared to talk about option 2, which is bidirectional exchange.
Thank you, Vicky, and good afternoon, everyone. So let's talk about bidirectional exchange here. This is that second option and that next level of connectivity for the HIE objective. Bidirectional exchange refers to two-way real-time communication of patient data between a provider's EHR system and health information exchange to support transitions of care. This is a yes/no attestation, unlike sending and receiving. Eligible clinicians that elect to use this measure must attest that the exchange he or she participates in occurs for every patient encounter, transition of care, or referral, and that a record of all exchanges is stored and maintained in the EHR in accordance with applicable laws. You must also attest that the HIE you participate in is capable of exchanging information across a broad network of unaffiliated exchange partners and does not engage in any exclusionary behavior. Lastly, you attest that you use the functionalities of your certified EHR to support the bi-directional exchange. Essentially, you need to have the functionality turned on for every patient, keep a record of the exchanges that are taking place for your patients, and make sure that your vendor is able to share that information out across the broad network. Bidirectional exchanges are a query-based HIE, and as Robin explained earlier, this is as simple as searching for a patient's name or an MRN and retrieving their medical information, as long as it was made accessible by other healthcare providers, public agencies, or any other source. Bidirectional exchanges are integrated within your EHR system. This could be like your HIE Platinum connection, some other examples. Commonwealth Health Alliance also has a bidirectional exchange that integrates with eClinicalWorks and Meditech. Greenway Health integrates with Premise Health and Epic Systems as well. But what this means for you is getting to that next level of connectivity that leads to increased information sharing, ultimately leading to better, more connected patient care. It also means less work for you and your staff, which is always going to be welcomed, I'm sure. Not having to search through any email catalogs, find contacts, and send those secure messages, and then having to wait for a reply is going to save you guys time as well. And as I mentioned before, this is a yes/no attestation, so you actually get a little bit of favorable scoring here. Let's say that you forget to send a request using the first option. You get dinged for that, and then it reflects in your numerator for sending health info. With bidirectional exchange, as long as that functionality is turned on for all your patients, you're going to get your full points here. I am now going to turn it over to Miss Robin, and she's going to walk us through some test points.
Thanks, Jared and Vicky. we hope we don't make you all dizzy by jumping around like this, but it breaks it up for you all and for us. And as Jared mentioned with bidirectional, it is an increasing level of connectivity for interoperability. And then TEFCA is the next step after bidirectional connection. So as mentioned earlier, TEFCA is an acronym because we don't have enough of those for Trusted Exchange Framework Common Agreement. As I mentioned, this describes a network of networks that are governed by what the Office of National Coordinator calls a recognized coordinating entity. So if a QHIN is composed of health information exchanges, the health information exchange, oh, let me back up just a little bit. So some terminology here that we need to discuss real quick. So this acronym is actually two phrases just combined. So we have a common agreement, which establishes the terms and conditions for the governing of that exchange of information between the QHIN. And then that framework is really the umbrella term that uncovers the common agreement, the terms of participation for all participants, and then sub-participants. And then healthcare organizations fall into the participant and sub-participant section as well. So just know that you as a provider are going to fall under the participant or sub-participant level. So when we think about the qualified health information networks, I mentioned earlier that this is a network of networks. And so if you have a QHIN that's composed of a health information exchange, the health information exchange would be the participant, and those that use those exchange services, such as health systems, ambulatory providers, HIT developers, payers, and others, they're considered the sub-participants. Benefits of participation. The Sequoia Project website is the current recognized coordinating entity. And so they list benefits of participation to include that it's an efficient vehicle to send, receive, and query for standardized electronic health information from a broad array of participants across a national scope. This can help providers improve care, provide individuals with access to their information, make it more of a one-stop shop for patients, improve care coordination, access information to support your value-based care requirements, care management, population health, and then reduce the need to participate in multiple health information exchange initiatives. And then additionally ease the public reporting, and then increase confidence in the data received from each other. So the purpose is, as I mentioned, it's a network of networks. And so if some of you are currently connected maybe to KHI through their platinum service, but yet you've also got another connection coming in through your vendor because maybe some of your referral partners, they don't talk, for lack of a better description. TEFCA is supposed to eliminate that so that you can only have to go one place to get information or share it. So some advantages to TEFCA, I mentioned them earlier: improving care, one-stop shop, but also increased confidence in data. So for you need to understand the terminology that we've just presented a little bit, understand your vendor capability, and then ask about connection verification. We sign a lot of documents, but how do we honestly know it's working as it's intended? So ask the questions, make them show you how it works, and then run reports. Ask them about data. So how can I be confident? When we work with you individually, we talk about your gap analysis, and I have folks who are using the bidirectional exchange, but I use their send and receive numbers as a test of whether or not things are actually populating as they should. They're still going to report bidirectional. In this case, they're going to report TEFCA, but is it actually working the way it's intended? So be sure to ask questions like that. To use this measure, you're going to attest to the following two statements: that you participate as a signatory to a framework agreement, and that agreement and that QHIN is in good standing and enables secure bidirectional exchange of information for every patient encounter, transition, or referral, and it's maintained in the EHR during that performance period. And the requirements are that you have to use the function of a certified electronic health information technology to support this bidirectional exchange underneath that framework agreement. And most importantly, it needs to be functional the entire reporting period. This is not something that you can start 60 days after the start of the reporting period. So if you intend to use the last 180 consecutive days, that means it needs to be in place by July 5th. So when we talk about HIE exchange, the benefits, ultimately it improves quality and safety of patient care by reducing medication and medical errors. I mean, how many times do your patients present and they may not know their entire medication list? They only know what the medicine looks like. This allows for improved communication. If you've got patients that are seeing multiple providers, and we are improving our interoperability by documenting what prescriptions have been ordered, you can question patients about that, and you'll get a better picture. And doing that with every visit keeps it up to date. It stimulates patient involvement in their own health care. We are seeing more folks using their patient portal. We're seeing more folks go to the portal to present their medication list when we have folks in the hospital. It eliminates unnecessary paperwork. I know that we still have this thing that if it's not in our hands, maybe it's not really there. And I know we have folks that really like to have that paper chart and just something quick to refer to because there's so many clicks. But ultimately, it's all in one place. Nothing can get lost, like papers can get shuffled. It reaches more to the goal of providing interoperability among EHRs. You know, when meaningful use came out, CMS said, gave you a sort of a framework or a template of what you've got to include, but you know, they didn't talk, they didn't share, they all got to the end goal, but through different methods, and they didn't always all align. So they really didn't communicate well. Then overall, it should reduce health-related costs. Think about it, avoiding duplicate testing. Now we have image exchange, so we can actually see films. We don't just get reports, but we actually get the pictures now. Folks, you know, we monitor how much radiation they get from multiple scans and CTs and things like this. This should reduce those costs. You will know ahead of time. You can chart scrub for patients who might need specific labs or other testing done, and then eliminates that redundant or unnecessary testing that I've already mentioned. So finally, I'm going to turn this back to Jared, and he is going to finish out our webinar for today.
Thank you, Robin. Alrighty, so now we've talked about each option. We've talked about some best practices, some benefits, considerations. Let's talk about some points that are associated here with the HIE objective. I'll keep this one pretty brief here. We've kind of hammered home scoring in this series already, but here's a quick breakdown of health information exchange. As Vicky talked, sending and receiving is a numerator and denominator score that needs to be reported, and each of those is worth 15 points. Bidirectional exchange and TEFCA are just those attestation statements, and those are worth the full 30 points for the objective. I wanted to do a scoring breakdown here, kind of as I mentioned earlier, that the scores can differ a little bit. But this breakdown here is looking at sending and receiving. So in the numerator and denominator scores, looking at it right here, the first example, you can see that they got 65 out of the 90 requests sent to them for those transition of care documents. This is going to give us 10 out of 15 points for sending. And we received all 3 of our documents that were requested from other organizations. So we'll get the full 15 points there. So in this example for HIE, we're going to get the 25 out of 30 possible points. And our final PI score is going to be 18.1 there at the bottom. But if we look at it compared to using bidirectional exchange here, everything else is the same, performance across all other objectives, and you can see that difference. They attested yes to using bidirectional exchange, going to get their full points there. That actually jumps the final score up to 20.6 points, 2.5 points higher than if they're using sending and receiving. So like I mentioned earlier, as long as that functionality is on for every patient, you really do get that favorable scoring. Next, we'll take a look here at some reweighting scenarios that can take place. There are a couple of things that can happen here. If your clinician is transferring or referring patients less than 100 times in the performance period, those 15 points can be related to the clinician's provider-to-patient exchange measure. If your clinician receives fewer than 100 transitions of care or referrals during the performance period, then those 15 points can be related to the sending portion of this measure. If they're taking the exclusion across the board for sending and receiving, all 30 of those points for HIE will roll up into provider-to-patient exchange. There are currently no exclusions available for bidirectional exchange or TEFCA at this time. There are some extreme and uncontrollable circumstances that can cause a shift here. Those are pretty rare, and CMS provides guidance on how those are affected and handled. All right, folks. As we really begin to wrap up this series here, we think it's important to really hit on some key takeaways from our three-part series. First things first, and probably old news by now, but the performance period has moved to that 180-day window for PI, and the category contributes 25% to your final score. Next, we talked in our first webinar about the new requirement for public health and clinical data exchanges having to be in that active engagement phase for 2025. Also, from the first webinar, there are substantial changes coming to the SRAs and the HIPAA privacy security rule just in general that you should be aware of. The REC HIPAA team does have a webinar recording out that's available now. So reach out to your advisor if you missed it, and we can get that over to you to watch. Next, your vendor is really going to determine a lot of your capabilities here in PI. So start that conversation early in the year with them to figure out exactly what you need to do to receive credit for things like provider-to-patient exchange or health information exchange. Looking here at number 5, it's good to have an idea by mid-year on who and how you plan to submit your data. Third parties do have requirements that have to be met by certain deadlines, and you don't want to miss anything because you started planning for attestation a little too late. Next, make sure to capture your documentation as you go when it comes to things like provider-to-patient exchange, querying the PDMP, or e-prescribing. You'll save yourself so much time when attestation rolls around. You won't have to go digging or looking for anything to validate your performance. Number 7, as a reminder, that if there are multiple submissions in the PI category, CMS will assign the highest score to you. And last but not least, one final plug for HIE here. We are truly lucky in Kentucky. HIE is kind of the one-stop shop for promoting interoperability, and they make it easier on you guys and on us. But it can take some time to get everything set up. So go ahead and get in contact with your regional rep now and get that ball rolling on getting more connected. All right. If today was the first section of the series you were able to tune into, don't worry. We have the links attached here in this presentation to our previous 2 webinars. This one will be sent out shortly for your convenience, and those hyperlinks will take you directly to the other 2. Covered a lot of great information in the PI category over the past 3 months, so be sure not to miss out on anything. Alrighty, ladies and gentlemen, that brings us to our question portion of the webinar. We've got a little bit of time left over here. So if you have any questions, please drop those in the chat or the Q&A, and Robin, Vicky, and I can answer those for you. I'm not seeing anything come through. If you do have questions later on down the road, please don't hesitate to reach out to me, Robin, or Vicky, or your advisor. We'd be happy to get those questions answered for you, or talk through any scenarios that you think might happen with your organization. Taking a look ahead at our schedule, our team will be kicking off the Accountable Care series on May 13th, talking about patient-centric care. And then on June 10th, REC advisors will continue that series, talking about decoding ACOs and APMs. And as always, the REC is here to assist you and be your trusted advisor in this ever-changing, complex world of healthcare we are living in. So do not hesitate to reach out with any questions concerning any of our service areas. We have a whole host of advisors that are willing to jump right in and offer a helping hand to you guys. Shoot us an email, give us a call, or check out our website for more information. The REC is also on Facebook, X, and LinkedIn, and we'd love to connect with you on those platforms as well. Thank you, everybody, for tuning in today and tuning into this Expert Insight series around promoting interoperability. Have a wonderful rest of your day, and we'll see y'all next month.